Thank you very much for your invitation to speak at this event. It's very nice to speak to you all. I'm just going to give a brief overview of the relevant ocular anatomy because some people may be less familiar with all that. So hopefully that will be helpful. And then we'll talk about the eye and its involvement with cystinosis in a little bit more detail. I'll spend a little time talking about the diagnostic tests that can be done to assess the impact of cystinosis on the eye. And then we'll talk about the treatment of the corneal crystals that develop in cystinosis, just going a little bit back into the history, our experience so far in Manchester. And then the big news is the introduction of cysto drops into practice and what to expect from switching patients to cysto drops from the current treatment. So just to go over the anatomy, so we break up the eye into an anterior segment and a posterior segment. So the anterior segment is all the focusing bits of the eye, the cornea, the clear window at the front of the eye, and the lens, which does the fine tuning of the focus. And the posterior segment, which is principally involved with converting light into electrical signals. That's the retina that does that, and that sends it from the eye down to the brain through the optic nerve. So the cornea is the transparent window at the front of the eye, and it's the main focusing part of the eye. And the corneal ultrastructure here on the microscopic image shows that it's a relatively simple structure, but it has various layers in it. The thin surface layer called the epithelium, and that lies on a layer called Bowman's membrane. And then the bulk of the cornea is taken up by this tissue. I'll just put my pointer on if that helps, laser pointer. There we go. This area here, I hope you can see, which is the corneal stroma. And then on the very back part of the cornea is this layer called the endothelium. And just going through some of the functions. So the epithelium is obviously a protective layer on the front of the eye. It's got a very rich nerve supply, and I'm sure any of you that had a scratch on your eye will probably realize how painful that is, and that's because of this nerve supply. But it's not only involved in pain reception, it's also involved in keeping this surface layer healthy and turnover of epithelial cells. So it's very important you have a good nerve layer here. And then just going back to that deepest layer, that's the endothelium. This is a lovely hexagonal mosaic of cells which are tightly packed. We've got 3 lifetimes worth of these cells present within our cornea, because once they're lost, they don't grow back. And they serve a very important purpose as they're mini pumps which pump fluid out of the cornea and keep it a nice compact structure, and that maintains its transparency. And on the front of the eye, in the white of the eye, you've got a mucous membrane which keeps the surface of the eye nice and moist. This covers the white of the eye called the conjunctiva, and that wraps around the inner surface of the eyelids as well. So the conjunctiva is very important for keeping the surface of the eye very healthy. And then moving on to the posterior segment again, the retina is this light sensitive tissue at the back of the eye, and it's involved in changing light into electrical signals. The retina has a very complex structure, as you can see from this optical coherence tomography scan of the back of the eye. There's various layers. So this outer layer of the retina is principally the sensory part. This is where the photoreceptors are, and they're the ones that change light into electrical signals. And then this inner layer of the retina is principally the nerve and the nerve fibers, which then process that signal and send it down the nerve fiber layer to the optic nerve. So moving on to cystinosis in the eye, there are clearly important signs and symptoms to talk about. And then I'll talk about the treatment options available and introduce some clinical trial data. And then also talk about the introduction of cysto drops into clinical practice. So signs and symptoms, the ocular features of cystinosis comprise an array of symptoms. Principally, it's photophobia, and the photophobia is due to this accumulation of crystals. You can see this picture here. The crystals scatter light and cause glare and closing of the eyelids called blepharospasm. In early infancy, it may just appear as a watery eye, and many young children that I see will often complain of itching sensation and a foreign body sensation, something in the eye. And in terms of vision, we know that it reduces some contrast sensitivity. So seeing grey writing against a sort of a whitish background can be more difficult, and it can be more challenging in certain lighting conditions. You get crystals deposited in all the ocular tissues. So in this picture here, you can see these little bright reflective blobs here, which are cystine crystals in the conjunctiva. They're also present in the underside of the eyelid on the conjunctiva. There's these little white deposits. And in the cornea, this is a scan again of the front of the cornea through its sections. And you can see these little white reflective flecks present within the cornea. These are crystals in the corneal layers. And it starts off in the periphery in infancy, and it spreads centrally and posteriorly. It's also present in the iris, and then here there's some crystals present on the surface of the lens of the eye. So even on the lens capsule, it can be present. So crystals are present from quite early on. So usually noticeable in the peripheral part of the retina, of the cornea, from about 5 months, and then there's rapid progression of crystal deposition over the first couple of decades. So you can see a rapid accumulation centrally, and usually by 16 months of age, the crystals have started to present themselves in everyone. And in the first couple of decades of life, the crystals rapidly increase in density. With ocular cystinosis, where there's no renal involvement, no kidney involvement, it is a milder form, and as such, there's less acceleration of this crystal deposition, so it takes a little bit longer. With regard to the retina at the back of the eye, you do get, without treatment, that is, you do get some changes in the back of the eye, and this can appear as a retinopathy. So you'll start to see these little white pigment losses of patchy pigment loss in the mid periphery, and then you can get some central retinal involvement with some atrophy and thinning of the central retina. And then the other the other issue we need to be just aware of is that sometimes with cystinosis, we can find that the pressure inside the head can become elevated, and this is visible in the eye as swelling of the optic nerves, and this is an example of swollen optic nerves following cystinosis. So in terms of what happens to the cornea as a result of increasing crystal deposition, this results in increasing damage to the ocular surface, and it can result in some deposition of mucous filaments. This is a filamentary keratitis, so these little blobs here are mucous strands, which can result in recurrent erosions of the cornea. They're increasing damage over a long time, which can result in scarring and vascularization. There's also other changes in the front part of the eye with iris thickening, inflammation, and high pressure developing in the eye. So what we want to try and do is try and assess how much crystal deposition there is present in the cornea. And this is a standard technique using a slit lamp biomicroscope many of you may be familiar with. And you can grade how much crystals are deposited in the cornea. This is a crystal grading system based on a publication by William Gall. This is the corneal crystal score. And you can see a panel here on your left with increasing crystal deposition and a score that increases from 0 to 3 in 0.25 unit steps. There are other ways of assessing crystal deposition. So a device called an optical coherence tomography scanner can use technology called interferometry to get a cross-sectional image of the cornea. And this is what it looks like. with the crystals appearing, as mentioned before, as these little bright white reflective areas near the front of the eye, front of the cornea. And you can measure how deep these are. So this is an example of a young person who's got crystals deposited just underneath the epithelium, and they're at a depth of 114 microns. The corneal total depth is 549 microns. So it's about a fifth of the depth. A more precise way of localizing crystals is using this remarkable device called an in vivo confocal microscope. So this makes contact with the front of the eye, but by doing so, it can get very high definition and high resolution images of the cellular layers of the cornea. And you can see the crystals in great clarity, and you can actually measure that density and give a more accurate score of how much crystals are deposited in the cornea. But you can also see other tissues in there. You can see the corneal nerves, and you can look at other inflammatory changes. So this is the sort of images you can get. So this is cellular layer of the epithelium. You can see the individual cells there. This little white strand here is a corneal nerve, and these little blobs here are the keratocytes, which are present normally in the stroma. And this is the endothelial cell layer and the deepest layer of the cornea. So very high resolution imaging at the cellular level. And looking at crystals using the confocal microscope, you can see the crystals in the corneal layers. This is the epithelial layer with increasing crystal deposition. And the crystals appear as these bright white needle-shaped structures, both in the epithelium and in the stroma here. So this is a normal stroma, and here you can see a stroma that's got lots of needle-shaped crystals present throughout. So putting that together, the confocal microscope images here and the OCT, optical coherence tomography images here, you can see this is a 13-year-old with cystinosis. There's crystals probably in the anterior third, and you can also confirm that with the confocal microscope. The anterior 2/5 have got crystals. The posterior layers here are without or with minimal crystals. There's another technique which we've been looking at here in Manchester, which is corneal densitometry. This uses a very standard device in most eye units called a pentacam, and this measures the transmissibility of light through the cornea and how much it's blocked. So this is called corneal densitometry. It's a standard piece of software on the machine, so it's available to everyone who's got one of these devices. And you can see that it gives you a reading of how transparent the cornea is. The lower the figure, the more transparent it is. The higher the figure, the less transparent it is. And we've used this to look at our patients with cystinosis to measure their densitometry. And so in green here are our patients with cystinosis, and in red, these are normal age-matched patients. And you can see the densitometry readings are much higher, and significantly higher actually, in many layers of the cornea as measured with this pentacam. And the beauty of this is that this is a very quick measurement as opposed to using the other techniques. This is a rapid and automated objective measure of corneal density. And comparing it to the corneal crystal score, which is the slit lamp photography score, it's actually much more able to measure higher levels of corneal crystals than the standard corneal crystal score. So just going through some of the treatments for corneal crystals, back in the history of this, Kaiser Kupfer published some early results of using cysteamine in an eye drop form, which resulted in a striking decrease in corneal crystal deposition. And remember, the oral cystagon medication or oral cysteamine was not effective in clearing corneal crystals. So this was the first demonstration that topically applied cysteamine could help that. And then various studies since then have also demonstrated some benefits from using topical preparations. For some time now, we've been using this aqueous preparation prepared by St. Thomas's and Guy's Hospital Pharmacy, which is a 0.55% aqueous solution. And its recommended dose is 1 drop every hour to both eyes. And we just went to see how effective this was in our patients. All the patients in Manchester that had cystinosis were looked at between 1994 and 2017. They were referred to us by the Paediatric Nephrology Department, and 16 of the patients at the time of this publication remained under our care. All patients were using cystamine eye drops, except for one patient who declined its use. Now, 11 of these patients were prescribed by the nephrologist first, and usually prescribed at a frequency of 4 times a day. And then 7 patients were commenced on the treatment 4 times a day by ophthalmologists. And we tended to prescribe these quite a lot later in the onset of the disease. So the median age at commencement of eye drops was around 7.5 years. So this is quite a delay. In terms of eyesight in these patients, this is a measure of eyesight called logMAR. And you can see the logMAR chart. Some of you will be familiar with this. Usually the good levels of vision are down here. This is 0.0 logMAR. You can see that most patients actually have excellent vision as measured by this chart. So that really doesn't pick up an issue. But the other chart we can use is this Pelly-Robson contrast sensitivity chart. And you can see letters all the same size, but fading away into the background. And what we can see in our cystinosis patients is normal contrast sensitivity is just over 2. So most of our patients have reduced contrast sensitivity in one or other eyes, or generally in both eyes. So that does pick up an issue. And then in terms of symptoms, patients will, on the whole, record mild or moderate degrees of photophobia in the vast majority of cases. In terms of using the eye drop that we were talking about, most patients are probably managing the eye drops about 6 times a day. So using it on an hourly basis is really quite a tall order. And one of the issues that many patients will tell us about is the side effects, and that's the stinging of the eye drops. The eyes tend to go red, they get a bit watery. There's a bit of swelling of the eyelids, blurred vision, itching and pain. And you can see that of our patients, most patients will have at least one side effect, but many have multiple side effects from using the eye drops. In terms of how has this affected their corneal crystals? Well, not much. Most of the patients have actually got sort of high levels of crystal in their corneas, so not much influence there. But this is an example of one child whose parents were very, very good at managing to get the eye drops in every hour. And so this is when she first came to us. You can see lots of crystals in her cornea. We had a chat with the parents. They really were up for putting the drops in every hour, and so was she. And then after 12 months of use, it's almost entirely cleared. And we can also see that on our OCT scan. Here you can see bright white flecks of the crystals, almost half thickness of her cornea. And then this is after a year. There's hardly any visible. There's a few there, but it's mostly cleared. So quite impressive improvement. But the problem with topical cystamine is it penetrates very poorly through the corneal epithelium. That's a barrier, as you know. Regular administration 12 times a day is quite a tall order. And many of you will be very familiar with the fact that it's unstable at room temperature, has to be kept in a refrigerator. It oxidizes very quickly to an inactive cystamine compound. It stings. That makes its use very frequently difficult. And some studies have indeed showed that very little benefit of using it, even 2-hourly, for over 4 years. So in an effort to try and improve outcomes from using cyst drops or cystamine eye drops, this new compound, Cystadrops, was made by Recordati or Olfin Europe originally. And the essence of this was it was a viscous eye drop. So in order for it to work more effectively, the theory is if it can stay on the surface of the eye for longer, it's more effective at penetrating, and it can clear the crystals more effectively. And their pivotal study was the CHOC study, which was 32 patients, half of whom were randomized to using this new compound Cystadrops, and the other half had the standard preparation, aqueous preparation, which was a slightly weaker strength of 0.1%. And they were prescribed it 4 times a day, both Cystadrops and the existing medication. You'll see from here that actually most patients were already on cysteamine, the normal preparation, for at least 144 months. So it's patients were already on this treatment before introducing the Cystadrops. In terms of the outcomes, they were using the confocal microscope, as mentioned before, to measure and quantify the amount of crystals in the cornea. And they could quantify a reduction in the amount of crystals in the cornea in the Cystadrops treated group, which dropped by about 40% by 90 days, compared to just a very modest 0.7% drop in the treatment arm that was just using the standard aqueous preparation. And then also looking at photophobia. So 2 graphs here. The graph above is the standard treatment group, and the graph below is the Cystadrop treatment group. In the standard treatment group, the photophobia score here is in the red dashed line, and we can see actually during the course of follow-up, their photophobia actually increased slightly, whereas in the Cystadrops group, over the course of follow-up, this blue dashed line measures photophobia, and there's a parallel decrease in photophobia over time, paralleling the decrease in crystals in the solid line above that. So as mentioned before, the NHS England Specialised Commissioning Body finally commissioned the use of Cystadrops for patients over the age of 2, and that was done sort of earlier in this year. Cystadrops is prescribed at a dose of 4 times a day, and in theory, over time, it could be reduced to about 2 or 3 times a day if it's shown to be efficacious in your patient. It does contain a preservative in it called benzalkonium, so that can be a little bit damaging to the ocular surface if it's used in excess. So monitoring is important. And then it's important to give advice to people who wear contact lenses, because benzalkonium soaked into a contact lens will cause damage to the ocular surface. So you can't really use contact lenses with this. Now, one of the good things about this drop is it doesn't need to be kept in the refrigerator after opening. So once you open it, it's stable at room temperature for 7 days. So that is a big improvement in ease of use. It's normally, the plan is for this to be delivered to patients at home through a home care delivery service. It needs to be constructed, so there's some instructions here about how to construct it. It's relatively straightforward, and shouldn't cause too much difficulty for patients to use. But it's important to be aware of the side effects. So we know that the side effects from just normal topical cysteamine aqueous drops does cause these kind of symptoms of pain, blurred vision. And I suspect with the viscous solution, these symptoms may well be a little bit more exaggerated. And in fact, when you looked at the side effects from the CHOC study in patients on conventional treatment versus this one, there was a little bit more in the way of these side effects present in the Cystadrop treated group. And it's not surprising, because it just stays on the ocular surface for a bit longer. But as long as you understand that, that's the key thing, not to worry about it, because it is expected. And usually, with continued use, one would expect that this becomes less of an issue. So just in conclusion, cystinosis has a significant effect on the eye, and corneal problems will cause significant ocular surface disease, photophobia, and reduced contrast sensitivity. So if you can treat corneal crystals with topical cysteamine, there is a way of reversing this accumulation of crystals, which does require diligent use if you stick to the aqueous preparation, but the viscous solution does provide a way of managing this a little bit more effectively in people's to fit in with people's lifestyle. But it's important to explain that the potential side effect profile to people. I think one of the things that strikes me about people being treated with eye drops is that they want to know if it's effective and whether all this sort of discomfort is of real benefit to them. And I think it's very important to feed back to your patient somehow in a way that it's understandable and clear to them that there is a benefit to it. And I think some of the measurements that we do of corneal crystals, it's important for us to feed that back to patients so that they know that it's worth their while continuing with this treatment. So that's it. Thank you very much for allowing me to present, and I will hand this back to you.